Pancreatic Cancer Management, a resident level Q&A. Welcome to our podcast. Today, we will be discussing key questions and answers on the management of pancreatic cancer, structured in a formal question and answer format. Pause the video when you hear the word answer to attempt answering the questions. Let's begin. Diagnosis and staging question. What are the most common symptoms of pancreatic cancer? Answer. The most common symptoms include painless jaundice, which is typical for tumors in the head of the pancreas, epigastric pain that radiates to the back, unintended weight loss, nausea, and new-onset diabetes. Question. Which tumor marker is most associated with pancreatic adenocarcinoma? Answer. Carbohydrate antigen 19-9, also known as CA19-9, is elevated in approximately 80% of cases, but it is not specific to pancreatic cancer. Question. What imaging is first line for suspected pancreatic cancer? Answer. The first-line imaging for suspected pancreatic cancer is contrast-enhanced computed tomography of the abdomen and pelvis, following a pancreatic protocol. This helps assess resectability and vascular involvement. Question. What are the key computed tomography findings suggesting unresectability? Answer. Unresectability is suggested by encasement of the superior mesenteric artery or celiac artery greater than 180 degrees, occlusion of the superior mesenteric vein or portal vein, or evidence of distant metastases. Question. When is endoscopic ultrasound with fine needle aspiration used in pancreatic cancer diagnosis? Answer. Endoscopic ultrasound with fine needle aspiration is used when computed tomography findings are equivocal or when a biopsy of small lesions is needed for tissue diagnosis. Question. What is the role of positron emission tomography computed tomography in pancreatic cancer? Answer. Positron emission tomography computed tomography can detect occult metastatic disease but is not routinely required in the standard evaluation. Question. What is the American Joint Committee on Cancer 8th edition TNM staging for pancreatic cancer? Answer. T1 indicates a tumor 2 cm or smaller, T2 is greater than 2 cm, T3 extends beyond the pancreas, and T4 involves the celiac or superior mesenteric arteries. N1 indicates 1 to 3 positive lymph nodes, and N2 indicates 4 or more positive lymph nodes. Question. What is the significance of a carbohydrate antigen 19-9 level greater than 1000 units per milliliter? Answer. Such a high level suggests advanced or metastatic disease. Question. What is a double duct sign on imaging? Answer. The double duct sign refers to the simultaneous dilation of the common bile duct and pancreatic duct, usually due to a mass in the head of the pancreas. Question. What is the differential diagnosis for a pancreatic head mass? Answer. The differential includes pancreatic adenocarcinoma, intraductal papillary mucinous neoplasm, neuroendocrine tumor, chronic pancreatitis, and metastasis. Surgical management question. What is the only curative treatment for pancreatic cancer? Answer. Surgical resection is currently the only curative treatment. The Whipple procedure is used for tumors in the pancreatic head, while distal pancreatectomy is performed for tumors in the body or tail. Question. What are the criteria for borderline resectable pancreatic cancer? Answer. Borderline resectable pancreatic cancer is characterized by limited involvement of the superior mesenteric or portal vein, and up to 180 degrees encasement of the superior mesenteric or hepatic arteries. Neoadjuvant therapy is often considered. Question. What is the Whipple procedure? Answer. The Whipple procedure, or pancreaticoduodenectomy, involves resection of the pancreatic head, duodenum, gallbladder, distal stomach or pylorus, a portion of the jejunum, and regional lymph nodes. Question. When is a distal pancreatectomy indicated? Answer. Distal pancreatectomy is indicated for tumors located in the body or tail of the pancreas and frequently includes splenectomy. Question. What is the mortality rate of a Whipple procedure at high-volume centers? Answer. The mortality rate for the Whipple procedure is less than 5% at high-volume centers. Question. What are the major complications of a Whipple procedure? Answer. Major complications include pancreatic fistula, delayed gastric emptying, hemorrhage, and infection. Question. What defines a pancreatic fistula according to the International Study Group on Pancreatic Fistula Criteria? Answer. A pancreatic fistula is defined as drain output greater than 50 milliliters per day with amylase content exceeding 3 times the serum level after postoperative day 3. Question. How is a grade B or C pancreatic fistula managed? Answer. Management includes keeping the patient nil paras, providing total parenteral or enteral nutrition, administering octreotide, ensuring drainage, possibly by interventional radiology, and antibiotics if infected. Question. What is the significance of an R0 versus R1 resection? Answer. R0 indicates negative margins and provides the best survival outcomes, while R1 indicates microscopic involvement of the margins. Question. What is the 5-year survival after R0 resection? Answer. The 5-year survival rate after R0 resection is approximately 20 to 25%, with higher rates if lymph nodes are negative. Question. What is the role of laparoscopic or robotic surgery in pancreatic cancer? Answer. Minimally invasive approaches are increasingly used for distal pancreatectomy, while the Whipple procedure remains predominantly open. Question. When is total pancreatectomy considered? Answer. Total pancreatectomy is considered in cases of multifocal disease or when positive margins persist after completion pancreatectomy. It results in brittle diabetes. Question. What is the Appleby procedure? Answer. The Appleby procedure involves distal pancreatectomy with celiac axis resection for locally advanced tumors of the body of the pancreas. Question. What vascular reconstructions may be needed during the Whipple procedure? Answer. Vascular reconstructions may include superior mesenteric or portal vein resection with primary anastomosis or the use of a graft such as polytetrafluoroethylene or autologous vein. Question. What is the role of extended lymphadenectomy? Answer. Extended lymphadenectomy has not demonstrated improved survival compared to standard lymphadenectomy, which includes peripancreatic lymph nodes. Neoadjuvant and adjuvant therapy. Question. When is neoadjuvant therapy used in pancreatic cancer? Answer. Neoadjuvant therapy is used for borderline resectable or locally advanced disease, typically with agents such as FOLFIRINOX or gemcitabine and nab-paclitaxel. Question. What is the most effective adjuvant regimen after resection? Answer. Modified FOLFIRINOX has been shown to be superior to gemcitabine alone in the PRODIGE 24 study. Question. What is the benefit of adjuvant chemotherapy? Answer. Adjuvant chemotherapy improves median survival, increasing it from approximately 11 months with surgery alone to about 20 months. Question. When is adjuvant chemoradiation used? Answer. The use of adjuvant chemoradiation is controversial but may be considered for margin-positive or node-positive disease. Question. What did the SPAC-1 trial show? Answer. The SPAC-1 trial showed that adjuvant chemotherapy with gemcitabine improved survival, whereas adjuvant chemoradiation did not. Palliative care. Question. What are the palliative options for obstructive jaundice? Answer. Palliative options include endoscopic retrograde cholangiopancreatography with placement of a biliary stent, preferably metal for patients expected to survive more than 6 months, or surgical bypass such as hepatojejunostomy. Question. When is a gastric bypass, gastrojejunostomy, performed prophylactically? Answer. Prophylactic gastrojejunostomy may be considered if there is concern for future duodenal obstruction, though this remains controversial. Question. What is the celiac plexus block used for? Answer. Celiac plexus block provides pain relief in unresectable disease by injecting alcohol or phenol under endoscopic ultrasound guidance. Question. What is the median survival for metastatic pancreatic cancer? Answer. Median survival for metastatic pancreatic cancer is approximately 6 to 12 months, with FOLFIRINOX offering an improvement over gemcitabine. Miscellaneous and complications. Question. What is the most common location of pancreatic cancer? Answer. The most common location is the head of the pancreas, comprising about 60% of cases, followed by the body and tail. Question. What hereditary syndromes increase pancreatic cancer risk? Answer. Hereditary syndromes that increase risk include BRCA1 and BRCA2 mutations, Lynch syndrome, Peutz-Jeghers syndrome, and familial atypical multiple mole melanoma syndrome, which involves the page 16 mutation. Question. What is intraductal papillary mucinous neoplasm, and how is it managed? Answer. Intraductal papillary mucinous neoplasm is managed with surgical intervention if there are high-risk features such as dilation of the main duct or presence of a mural nodule. Question. What is pancreatic insufficiency, and how is it managed? Answer. Pancreatic insufficiency can be exocrine, managed with pancreatic enzyme replacement such as lipase, or endocrine, addressed with insulin for diabetes. Question. What is the most common cause of death after Whipple procedure? Answer. The most common cause of death is disease recurrence, either locally or as metastatic spread. Question: what is the sentinel acute pancreatitis event hypothesis? Answer: this hypothesis suggests that chronic inflammation, such as from pancreatitis, may promote the development of pancreatic cancer. Quickfire questions. Question: what is the classic histologic finding in pancreatic adenocarcinoma? Answer: the classic finding is desmoplastic stroma with gland-forming adenocarcinoma. Question: what is the most common site of metastasis? Answer: the most common site of metastasis is the liver, followed by the peritoneum and lungs. Question: what is the role of hyperthermic intraperitoneal chemotherapy in pancreatic cancer? Answer: hyperthermic intraperitoneal chemotherapy is not standard and remains investigational for peritoneal metastases. Question: what is the significance of a positive peritoneal cytology? Answer: positive peritoneal cytology is considered metastatic disease and renders the cancer unresectable. Question: what is the triangle operation in pancreatic surgery? Answer: this refers to a technique for superior mesenteric artery dissection during the Whipple procedure. Question: what is the risk of diabetes after distal pancreatectomy? Answer: the risk of diabetes is approximately 20 to 30%, which is less than after total pancreatectomy. Question: what is the most feared complication after Whipple procedure? Answer: the most feared complication is post-pancreatectomy hemorrhage, often due to blowout of the gastroduodenal artery stump. Question: what is the Whipple triad for insulinoma? Answer: the Whipple triad for insulinoma consists of hypoglycemia, symptoms during fasting, and relief with glucose. It does not pertain to adenocarcinoma. Question: what is the role of immunotherapy in pancreatic cancer? Answer: the role of immunotherapy is limited due to the low mutational burden of pancreatic cancer. It remains investigational in clinical trials. Question: what is the significance of a pathologic complete response after neoadjuvant therapy? Answer: a pathologic complete response is rare but associated with improved survival. Surgical anatomy and technical pearls. Question: what are the arterial blood supplies to the pancreas? Answer: the head of the pancreas is supplied by branches from the superior mesenteric artery and gastroduodenal artery, while the body and tail are supplied by branches of the splenic artery. Question: what is the vascular corridor for superior mesenteric artery dissection in a Whipple procedure? Answer: the vascular corridor is located between the superior mesenteric vein anteriorly and the superior mesenteric artery posteriorly. Question: which nerve plexus infiltration makes pancreatic cancer unresectable? Answer: infiltration of the superior mesenteric artery or celiac plexus renders the tumor unresectable. Question: what is the supracolic compartment in pancreatic surgery? Answer: the supracolic compartment includes the liver, omentum, and peritoneum, and is explored to rule out peritoneal metastases. Question: what is the ligament of Treitz, and why is it important? Answer: the ligament of Treitz is the suspensory ligament of the duodenum and serves as a landmark for the proximal jejunal transection in the Whipple procedure. Question: what is the mesopancreas, and why is it important? Answer: the mesopancreas is the retroperitoneal soft tissue behind the pancreatic head, which must be cleared for a margin-negative resection. Question: what is the gastroduodenal artery stump, and why is it a concern after Whipple? Answer: the gastroduodenal artery stump is a potential site for pseudoaneurysm rupture, which can lead to life-threatening hemorrhage. Question: how is the pancreatic anastomosis typically reconstructed? Answer: reconstruction is typically performed with a pancreaticojejunostomy or pancreaticogatrostomy. Question: what is the child's reconstruction after Whipple? Answer: child's reconstruction refers to the classic order of reconstruction: pancreas, followed by bile duct, then stomach. The Cadell-Warren technique reconstructs the bile duct first. Question: what is the Puisto procedure, and is it used for cancer? Answer: the Puisto procedure is a longitudinal pancreaticojejunostomy for chronic pancreatitis and is not used for adenocarcinoma. Landmark trials in pancreatic cancer. Question: what did the CONCO 001 trial show? Answer: the CONCO 001 trial demonstrated that adjuvant gemcitabine improved disease-free survival compared to observation after surgical resection. Question: what was the key finding of the PRODIGE 24/CCT-GPA-6 trial? Answer: the trial found that adjuvant modified FOLFIRINOX was superior to gemcitabine for patients with resected pancreatic cancer. with a median overall survival of 54 months compared to 35 months. Question: what did the ESP-4 trial demonstrate? Answer: the ESP-4 trial showed that adjuvant gemcitabine plus capecitabine improved overall survival compared to gemcitabine alone. Question: what was the outcome of the EMPACT trial? Answer: the EMPACT trial found that the combination of gemcitabine and nab-paclitaxel improved survival in metastatic disease compared to gemcitabine alone. Question: what did the ACCORD-PRODIGE 11 trial show for locally advanced disease? Answer: this trial found that FOLFIRINOX improved survival compared to gemcitabine in patients with metastatic or unresectable disease. Question: what is the PREAPANC trial? Answer: the PREAPANC trial showed that neoadjuvant chemoradiation with gemcitabine and radiation therapy improved R0 resection rates in borderline resectable disease. Question: what did the JASPAC-01 trial show? Answer: the JASPAC-01 trial demonstrated that adjuvant S1, an oral fluoropyrimidine, was non-inferior to gemcitabine in Asian patients. Question: what is the SWOG S1505 trial? Answer: the SWOG S1505 trial compared perioperative modified FOLFIRINOX with gemcitabine and nab-paclitaxel and found no difference in overall survival. Question: what did the APACT trial evaluate? Answer: the APACT trial evaluated adjuvant nab-paclitaxel with gemcitabine and did not find a significant improvement in disease-free survival compared to gemcitabine alone. Question: what is the Alliance A021806 trial investigating? Answer: the Alliance A021806 trial is studying perioperative modified FOLFIRINOX with chemoradiation for borderline resectable disease. Advanced topics and controversies. Question: what is liquid biopsy in pancreatic cancer? Answer: liquid biopsy refers to the detection of circulating tumor DNA for early monitoring of cancer recurrence. Question: what is the role of poly-ADP ribose polymerase inhibitors in pancreatic cancer? Answer: poly-ADP ribose polymerase inhibitors such as olaparib are used as maintenance therapy for patients with BRCA-mutated metastatic pancreatic ductal adenocarcinoma, as shown in the POLO trial. Question: what is the significance of cross mutations? Answer: cross mutations are present in over 90% of pancreatic ductal adenocarcinomas and are considered driver mutations, though they are not yet targetable. Question: what is the window of opportunity trial concept? Answer: this concept involves a short period of preoperative treatment to assess tumor biology, such as response to neoadjuvant therapy. Question: what is SMAD4 loss, and why is it important? Answer: loss of SMAD4 is associated with a worse prognosis and a higher likelihood of metastatic spread. Question: what is the mother duct sign in intraductal papillary mucinous neoplasm? Answer: the mother duct sign is dilation of the main pancreatic duct greater than 5 mm, indicating higher risk of malignancy. Question: what is the sentinel loop sign on imaging? Answer: the sentinel loop sign is a dilated jejunal loop near the pancreas, seen due to localized ileus from inflammation or tumor. Question: what is the colon cutoff sign? Answer: the colon cutoff sign is a distended colon proximal to pancreatic inflammation, observed in pancreatitis or cancer. Question: what is pancreatic acinar cell carcinoma? Answer: pancreatic acinar cell carcinoma is a rare tumor, comprising less than 1% of pancreatic tumors, but generally has a better prognosis than adenocarcinoma. Question: what is autoimmune pancreatitis, and how does it mimic cancer? Answer: autoimmune pancreatitis is an immunoglobulin G4-related disease that presents with a pancreatic mass and biliary stricture, but responds to steroid therapy. Complications and management. Question: what is delayed gastric emptying after Whipple, and how is it managed? Answer: grade A delayed gastric emptying is managed with nilperos for 1 to 2 days, while grades B and C require nilperos for over a week. Prokinetic agents such as erythromycin, and total parenteral nutrition. Question: what is post-pancreatectomy hemorrhage, and how is it classified? Answer: early hemorrhage, occurring within 24 hours, is usually due to technical failure, while late hemorrhage, after 24 hours, is often due to pseudoaneurysm formation at the gastroduodenal artery stump. Management may involve angiography, embolization, or reoperation. Question: what is pancreatic ascites, and how is it treated? Answer: pancreatic ascites results from disruption of the pancreatic duct and is managed with somatostatin analogs. endoscopic retrograde cholangiopancreatography with stent placement, or surgery. Question: what is the risk of diabetes after distal pancreatectomy? Answer: the risk is approximately 20 to 30% due to the loss of insulin-producing beta cells. Question: how is chyle leak after Whipple managed? Answer: chyle leak is managed with nil perostatus, total parenteral nutrition, and octreotide. Thoracic duct ligation is rarely required. Question: what is the Gray-Turner sign in pancreatic cancer? Answer: Gray-Turner sign is bruising of the flanks due to retroperitoneal hemorrhage, seen in severe pancreatitis or trauma. Question: what is Courvoisier sign? Answer: Courvoisier sign is a palpable gallbladder with jaundice, suggesting a malignant or pancreatic cause rather than gallstones. Question: what is pancreatic encephalopathy? Answer: pancreatic encephalopathy is a rare neurologic complication of severe pancreatitis or pancreatic cancer, manifesting as altered mental status. Question: what is Ogilvie syndrome after Whipple? Answer: Ogilvie syndrome is acute colonic pseudo-obstruction and is managed with neostigmine or decompression. Question: what is the risk of splenic vein thrombosis after distal pancreatectomy? Answer: the risk is approximately 10% and may lead to sinistral portal hypertension and gastric varices. Rare histologies and special cases. Question: what is a pancreatic neuroendocrine tumor, and how does it differ from adenocarcinoma? Answer: pancreatic neuroendocrine tumors are slower growing, often hormonally active, and may be treated with surgery or somatostatin analogs rather than standard adenocarcinoma therapies. Question: what is a solid pseudopapillary neoplasm? Answer: solid pseudopapillary neoplasm is a low-grade malignant tumor seen most commonly in young women and is generally cured with resection. Question: what is colloid carcinoma of the pancreas? Answer: colloid carcinoma is a subtype associated with intraductal papillary mucinous neoplasm and generally has a better prognosis. Question: what is metastasis to the pancreas from other primaries? Answer: renal cell carcinoma is the most common primary cancer to metastasize to the pancreas, and surgical resection may be considered. Question: what is pancreatic lymphoma, and how is it managed? Answer: pancreatic lymphoma is rare and is treated with chemotherapy rather than surgery. Final quick-fire questions. Question: what is the no-touch technique in the Whipple procedure? Answer: the no-touch technique involves early vascular control to minimize tumor manipulation. Question: what is the artery-first approach? Answer: the artery-first approach entails early dissection of the superior mesenteric artery to assess tumor resectability. Question: what is the radiology pathology correlation for pancreatic cancer? Answer: computed tomography hypodensity correlates with fibrosis or desmoplasia, and positron emission tomography avidity reflects high metabolic activity. Question: what is the surveillance protocol after resection? Answer: surveillance includes computed tomography and CA19-9 measurement every 3 to 6 months for the first 2 years, then annually. Question: what is the most common cause of death in resected pancreatic cancer? Answer: the most common cause of death is distant metastasis, most frequently to the liver and peritoneum, followed by local recurrence. Thank you for listening to this comprehensive discussion on the management of pancreatic cancer. Stay tuned for more in-depth discussions on surgical oncology topics.